for Zofran is C18H20CIN3O. That's its molecular formula. So that is the chemical name. Never will I ask you what a chemical name of a medication is, okay? But I do need you to know that medications are comprised of chemicals. The generic name is the name in which the FDA approved the medication to be given. So it is the name, I guess the best way for me to explain that is like it's the official name of the medication. Okay, so that would be ondansetron, like you said, Ashlyn. Now, the brand or trade name is Zofran. The very first company who comes out with a medication gets to call it what they wish. And that is its brand or trade name. And very often that is the name that we call it in everyday language. It's easier to say. And it was the first drug that was out. So it like, let's talk about, not everybody's familiar with Zofran. Let's talk about Tylenol. Most people don't say, I'm going to go take some acetaminophen. They're going to say, does anybody have Tylenol? I have a headache. Tylenol is the brand or trade name of that medicine, and acetaminophen would be the generic name. And again, the chemical name, not a clue, because it's in a lab, molecular level stuff that I don't care about. So as far as those as far as those generic and brand names, you need to know. There's some that I'm going to say you absolutely have to know this because everybody's going to call it that. But when you're giving medications in a hospital or clinic setting, that generic name will always be listed. So if you're picking them by importance, then one is not more important than the other, but the generic name should always be listed. Generic name will be lowercase. Trade name is generally capitalized. But the thing that a trade name has to have is that it's going to have a little trademark after it. So if you look on page, let's see, they're not going to have it. Everybody go to, if you have your phone in front of you, Google Tylenol and go to images. Just type in regular Tylenol. And I'm going to show you all on the screen if you don't have your phone in front of you. Okay. Can you guys see that little trademark after the L? Can y'all see that?
You're still sharing your screen.
Oh, hold on, let me stop presenting and show it to y'all. Can y'all see that trademark symbol? That's how you're gonna know. So you're gonna look at that capital letter, but the thing that it will always have, if it's a generic, if it's a brand or trade name, is a trademark, which is that little symbol right there. Can you guys see it? I'm gonna scroll out so you can. And then underneath it, it says acetaminophen, which is actually capitalized in this case, but it does not have the trademark next to it. So that trademark is the primary thing that you're looking for to determine if something is a generic drug versus a trade name or a brand name, okay? Now your patients, they are going to very, very often refer to their drugs by that brand or trade name. They're not going to refer to them usually by the generic name. The longer you're a nurse, the more you will recognize those things, okay? So I'm going to share my PowerPoint again. So those are the three types, all of that to say those are the three types of drug names. All right. All right, so as far as classifying drugs can be classified based on the type of drug that they are or what they do in the body. So let's go back to Tylenol. You don't need to know Tylenol, but I need to be able to give you some examples that you can understand. What is Tylenol used for? I want two different things that it's used for.
Pain reliever and fever.
Yes. So it could be used for pain or it could be used for fever, right? Same drug, two totally different uses. So it can be classified as an antipyretic, which would be for fever, and it could be classified as an analgesic, which would be for pain. So as we learn about medications, you'll look at the classification that they are in. So that's something important to keep in mind, because sometimes you're going to have antidepressants and anti-seizure medications that are in the same drug class. So when you go into your patient's room and you say, I have your Neurontin for your seizures, well, guess what? If your patient doesn't have seizures, you just totally freaked them out. They're like, what? I had a seizure? Oh my God. No, they're not taking Neurontin for seizures. They're taking it for something entirely different. So that is something that you need to keep at the forefront of your thoughts of, this medication can be used for XYZ, but what classification is it in as relates to my patient? Does that make sense to you guys? So in addition to those classifications, drugs can be prescription or non-prescription. They can be controlled substances, or they can be herbal preparations. So we have all kinds of medications that are thrown into the mix, okay? And it is important that we're going to talk about this a little bit more. For the purposes of taking care of our patients, we need to know about their herbal preparations that they're taking. We need to know if they're using CBD oil. We need to know if they are taking cinnamon. We need to know if they're taking fish oil. All of those things may not be listed as, they're not prescription medications, but they absolutely have an effect on your patient and the care that we're going to administer to them. So we always want to ask about herbal preparations. Okay, and we will go into controlled substances versus non-controlled substances in a little bit. And we will also talk about prescription versus non-prescription. Okay, so the FDA. We have to talk about some of the boring stuff in order to, to kind of lay the foundation. So the FDA is the Food and Drug Administration. It is going to determine what category a medication goes in. So the FDA is who determines whether a drug is non-prescription, prescription, or controlled. Okay. So normally, which it actually kind of works out good. COVID gives us a lot of real life examples that we wouldn't have normally had. It normally takes 7 to 12 years for a drug to be developed and approved by the FDA. That's a pretty solid time, huh? 7 to 12 years. That's your entire length of schooling for a drug to be approved. But the FDA can expedite that process if the need is great, such as the COVID vaccination. So normally the COVID vaccination would have had to go through all of these, this entire 4-phase thing, which it still goes through, but it is shortened greatly because the benefit of putting out that vaccine outweighs that risk of monitoring it for that extended period of time. So under normal circumstances, phase 1 of drug approval, you're going to have 20 to 100 volunteers, and they're going to see what the drug does to healthy tissue. So they're going to give the drug to healthy people and see what happens. Okay. Then in phase 2, they are going to give it to people who have the disease for which it might be effective. Okay. So that would be like, let's just go back to Tylenol. I'm just going to try to stick to the same example. So when Tylenol was first developed, they said, you know, this is a medication that we are going to give to people who have fever at home. So they gave it to people who didn't have fever just to see if they had any negative implications, just to see what does it do to these healthy people. Then they said, we're going to give it to these next group of people who have the disease for which the drug might be effective, or the symptom, not necessarily the disease. So now we're going to give it to all these people with pain and fever and see what happens. Then we're going to collect information. We're going to expand. If nothing crazy happened in phase 2, then we're going to expand and we're going to increase those 100 people to thousands of people. And we're going to collect all of the adverse or negative things that happened. So some people said this, and some people said it caused me to have a stomach ache, and they're going to gather all of that information. And that's where your side effects come in, okay? And then phase 4 is called post-marketing surveillance, and it's an ongoing review. So phase 4 is like when you see these commercials and they're like, oh, talcum powder is now known to cause da 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 da. That was recognized in the post-marketing surveillance of those drugs, okay? And those negative things were not seen immediately. They were seen later on in the game. So that's kind of that's the role of the FDA and how things normally work. All right, scheduling of drugs. So this always confuses students. The higher the schedule, the more risk or potential for abuse of a drug. Okay. Like, did I say the higher? See, I said it. And the higher on the, so if it's a 1, then it has the highest potential for abuse, if it's a Schedule 1. If it's a Schedule 5, then it has the lowest potential for abuse. Are y'all with me there? If it's Schedule 1, think it's the first drug that people are going to abuse. And then Schedule 5 is going to be less. So drugs are scheduled because what happens is, just like when you know, later on in the game, like I said, they might say, oh, well, this is known to cause such and such. Later on in the game, they'll say, oh, well, this is known to cause for patients to be dependent upon these drugs. So when we list when a drug is determined what schedule it is, that's something that has to be told to the patient. They need to be aware that this drug has a high potential for abuse and dependence. So the patient has a role and responsibility in knowing that. And the physician also carries a very high responsibility in knowing that, because we're not slinging out prescriptions. Well, as nurses, we're not slinging them out anyway, but physicians can't just sling out prescriptions for drugs that have high schedules, because then we end up in an opioid pandemic like we have now, because they didn't realize, A, they didn't realize, B, they didn't really care that these drugs had such a high potential for abuse. And we will talk about that later on. What you need to know today is that Schedule 1 drugs have a very high potential for abuse. And as it goes down, that potential decreases. Now you'll notice that Schedule 1 in there is listed heroin, LSD, marijuana, all of those things. You'll see that. So the DEA also has a role in scheduling drugs. So Schedule 1, there's really not a lot of, if any, actual medicinal drugs that are in that schedule. Those are usually the illegal, because they have an extreme risk for abuse and dependence, and there's really no medical or medicinal qualities to those things. So those schedules are assigned by the DEA. And then, you know, Schedule 2 would be high potential for abuse. and they do have medicinal qualities. So those are going to be your things like Adderall, Oxycontin, Vicodin, those types of drugs. So just know those schedules. You don't have to know the drugs in them, but you need to know the potential for abuse and stuff. All right. So any questions so far about that? I feel like I talked about it for a long time, but it's important to know. Y'all good?
Miss Traylor.
Yes.
You said that Adderall is considered Schedule 1?
Actually, Schedule 2.
Okay.
Yes, Schedule 1. Okay, so if Adderall were being taken, which that makes it complicated, but if you were taking it just to take it, just for fun, and you really didn't have a diagnosis that warranted it, it would have an even higher potential for abuse. But most prescription medications are not going to be listed as higher than a controlled substance 2. Usually your controlled substance, this little first group here, Schedule 1 drugs are usually going to be street drugs. So Schedule 2 drugs are actually going to be your highest prescription drug, your prescription drugs that have the highest potential for abuse.
Okay.
Does that make sense?
Yeah. Thank you.
So, and we'll talk about that later too. Does that mean nobody should take Adderall? No. If it's prescribed correctly and it's taken as indicated, and it's monitored and it's weaned and all of these things, you're not gonna be an addict all your life. But it's things that need to be recognized and brought forth to the forefront before a medication is began. And because of these schedules, things will, and stuff can move in the schedule. So like, just because something was once a Schedule 2, they can monitor it for longer and say, that's a Schedule 3, or, it can move. So, that's something that is fluid and ever changing. Any more questions about that? Okay. So drug activity. So there are 3 phases of drug activity, and this is what's happening inside of the body. The activity, that's what's happening to the drug once it is inside the body. So we have the drug. The pharmaceutic phase is when the drug is dissolved. So a medication cannot be used unless it is dissolved and it's made usable for the body. So when you swallow a Tylenol, when you swallow just a regular Tylenol pill, it's in whole form and it can't do anything, right? So the pharmaceutic phase of Tylenol would be when that drug dissolves in your stomach, okay? Pharmacokinetics, have y'all heard of kinesiology? Means movement. Okay, pharmacokinetics is when the drug is transported through the body, okay? So first it's got to dissolve, that's pharmaceutic. Pharmacokinetics is when it transports from where it is and it goes through the body so that it can be effective. We're going to talk a lot. So absorption, distribution, metabolism, and elimination. Those are the 4 phases within pharmacokinetics. Okay. We're going to talk in depth about each of those phases. So you need to put a big fat star next to that stuff. And then pharmacodynamics is the study of the drug mechanisms that produce a biochemical change in the body. So that is more how it actually works on the tissues. Do y'all understand the difference between those? Questions before we move on? It'll make a little more sense as we go through. Y'all still good? Okay. Okay, so back to pharmaceutic phase. So drugs can be, so y'all actually tell me, I'm going to go back. Type in the chat or tell me out loud some different forms of medication. Some different forms that meds come in. Catherine. What'd you say, Caitlin?
Meg.
I thought Caitlin said something. I'm sorry. Liquid? Somebody said liquid.
Said
Oral.
capsules.
I'm sorry, I keep talking while you're talking. I still didn't hear you. One more time, tell me.
Capsules.
Capsules. Thank you. Okay, I'm seeing them in the chat. Yes. So different forms of medications: liquid, oral, suppositories, sublingual, which is under the tongue, pills, patches. All of those forms are going to be transported and absorbed differently in the body. Okay. So the pharmaceutic phase is the phase in which the drug is dissolved, right? So the pharmaceutic phase will be shorter in a liquid medication than it will in a capsule or a sustained release pill. Do we all agree? Something that's already dissolved, they're going to absorb more quickly. Solid forms of a drug, like tablets or capsules, they have to first disintegrate into small particles and be dissolved into the body, into the GI tract in order for them to be made useful, right? And then enteric coated tablets, they're only going to disintegrate after reaching an alkaline environment. So enteric coated tablets are those tablets that are, they have that thick coating on the outside. I think I have one right here. Hold on. Okay, so we have bare aspirin right here, okay? I know you cannot tell by looking at this, but this thick coating that's on the outside of it, I don't know why I pulled it out because you can't see it. That thick coating stops this aspirin from dissolving until it reaches the alkaline environment of the small intestine. So that stops it from tearing up the lining of the stomach. Remember, we say aspirin is bad. I'm sure y'all have heard aspirin is bad for your stomach. So there are certain coatings that can be placed on medications that will combat that ability for it to dissolve in the stomach, and it doesn't really dissolve until it gets to the small intestine. What is that going to do to the time frame of the drug, that pharmaceutic phase? If it's enteric coated, is it going to be shorter or longer?
Longer.
Yes, it's going to be longer. So what about when we talk about IV medications? How about that pharmaceutic phase?
Shorter.
Shorter, super fast. It is going to be made for use in the body immediately because it is already dissolved and it does not need to travel to the bloodstream. All right. Now, pharmacokinetics. This is where, yes, ma'am, Opal.
Okay, when you say coating, are you talking about the capsule pills?
So capsules are a little bit different than enteric coated. Capsules you can pull apart, and we'll kind of look at some of that when we go in class. Capsules pull apart and they have powder within them. And so that capsule does still have to absorb. Enteric coated is like, it's almost like a candy coating, like a thick, I'll bring some to show you guys. It's like a thick, almost like if you hammered it, it doesn't even really break. It's really a thick coating on the pill. Capsules are different. They pull apart and the medication is dissolved within them. But a capsule is still going to dissolve more slowly than a liquid will.
Okay, thank you.
And I'll show you, remind me, I'm going to bring some drugs from home and show y'all kind of the difference of what y'all are looking at, okay?
Okay.
I see your hand up, Abigail. You can ask me.
Okay, so 2 questions. What's the difference between like a regular pill and a liquid pill? Is there any difference between the two, or are they actually just the same? You know, not a liquid pill, but like the gel pills.
In theory, a gel cap works faster. In theory, the onset is a little bit faster because less absorption takes place. Now, we're probably talking honest, true, probably 5 minutes, 5 to 10 minutes. Not anything substantial, but in theory, they work faster.
And then my other question was, with the capsules, obviously, once you pull them apart, the medicine is there. Like, what happens if the person just completely avoids the tablet, opens it up, and like puts the medicine on like something they can eat, and then they eat that with the medicine? Does that shorten the period?
Yes, because that outer coating does not have to dissolve. So we're going to talk about this. Those are good questions. So people who, for lack of better terms, want to high faster, you're going to notice some of your patients, when you give them a pain pill, they're going to chew it. It's not made to be chewed. It will work faster if it's chewed. Kind of the same principle with those things. And y'all are going to learn, if y'all want to make a note now, since we're already talking about that, some medications are made and they are extended release. So they'll say such and such ER or such and such SR, which is sustained release, or such and such CR, which is controlled release. Those medications are specifically designed to only give a certain amount of medication at a certain time, okay? So even though it may be absorbed, it only can move into that next phase at a certain time. So those types of medications should never be chewed or crushed, because it gets rid of that sustained release, what would you call it, mechanism that it has.
Gotcha. Thank you so much.
You're welcome.
I was gonna ask you something about like the Adderall XR and like the Adderall Instant. So like the Adderall XR, that would be like the solid forms of drugs, but then like the Instant, would that be part of like the dissolving like one? The
Okay,
first
so
stage?
what, I wish I had some actual examples to show you guys of that. I'm not going to go incredibly into it, but okay, so let's talk about Adderall.
Because I know the Adderall XR is a capsule, but then the Instant's like a little bitty like pill.
So the XR, what that has to do with is when it's, okay, so the instant Adderall, you're going to take more often. You're going to take it 3 times a day, as opposed to the sustained release, which you would only take once or twice a day, because it's delivered over a certain period of time. And that has to do more than the way the pill looks. It has to do with the onset, peak, and duration of the drug, which we will talk about. Each drug has different properties, and it's kind of, if you think of it like a hill. Can you guys see me? I'm gonna make it where y'all can see me. Hold on. All right, so we're gonna talk in a little bit about onset, peak, and duration. So let me draw this for you guys. So when we're talking about Adderall, different types of Adderall, this is kind of, onset would be at the beginning of this hill. Can y'all see my little hill that I drew? Onset, and I can't see anything. Okay, if you drew a hill, onset would be when the medication, let me just use my hands like this. Okay, onset would be when the medication first starts working, and it works and it works and it works. And then peak would be at the top of that hill. Okay. And then duration would be how long it takes to get to the bottom of that hill. So when we're talking about sustained release drugs, like your question about the Adderall, Sunday, and you're going to have your immediate and you're going to have your sustained and all of that, it has more to do with the onset, peak, and duration on how those drugs work than it does with the form in which they come. So the form does have a little bit to do with it, but it's not the only factor. Does that make sense to you? It'll make a little bit more sense when we talk about onset, peak, and duration. So basically everything to say this, everything we talk about in pharmacology, I always tell students, you can't have one box, okay? Because remember we talked about the Tylenol, and it can be an antipyretic and it can be an analgesic. In pharmacology, everything is going to link together and it's going to cross into each other, okay? So there's not going to really ever be any one answer to y'all's questions, because there's so many factors. Okay, so just so far, we've only been talking about pharm for 20 minutes, and factors we already have are onset, peak, and duration. We talked about the type of drug that it is. We've talked about, there's already 3 factors, and we haven't talked about age or diagnosis or any of that stuff yet. So I'm glad y'all are asking those questions, because that's a good time for me to say it's not always going to be black or white. There is a whole lot of gray area, whole lot. Questions? Did I confuse anyone? Okay, I'm gonna go back to my PowerPoint. All right, let's see. Y'all are quiet. All right. So, talked about all that. All right, so liquid and parenteral drugs are going to be your most quickly absorbed. That's important to know. Parenteral means not given by mouth. Okay, pharmacokinetics. This is where I'm really going to jump up and down on stuff, okay? I want y'all to remember the acronym ADME, A-D-M-E. That is the order in which medications, the pharmacokinetic process in the body works, okay? So this is a process. So after the drug is made into a liquid or dissolvable form, our body must absorb it. If it is not absorbed by our body, then we cannot do anything with it, right? We have to be able to absorb it. Okay, so let's talk about just a patch. Let's say I have a birth control patch. If I put it on top of my clothes, what I got? Nothing. If I can't absorb it, it can't do its job, okay? So you're going to hear us say a lot of things like don't put it on a hairy area, and all of that stuff seems like common sense, but always think back to absorption. Always think back, if we can't make it available for use, then it's useless, okay? So the first step is absorption. Distribution is when these medications bind to a protein and they transport it to the site of use, okay? So not all medications can be used in the gut where they originally dissolve, right? They have to be sent out into other areas of the body. So that is distribution, okay? Metabolism is when the body changes the drug to a more or less active, I'm supposed to say active form. So metabolism is when it actually starts doing its work, right? The body has broken it down and it's doing its thing. It's sending it where it needs to go. It's changing it to where it needs to be. It's binding to those receptors that it needs to bind to. And then excretion is when we get rid of it, when we eliminate it, okay? All right, so without me telling you anything else, what part of your body do you think is not absolved? What part of your body do you think is most involved in excretion, getting rid of?
Kidneys.
Yes. Who said that? Yes.
Emily.
Good job. So your kidneys. So if your kidneys stink, you gonna hold on to a drug longer, or are you gonna get rid of it faster? What's gonna happen with your drugs? If your kidneys stink,
Longer.
you're gonna hold on to it longer. And so those are things that I need you, these are the most basics of pharmacology. But when we start talking about patients and we give you all of this information and we say your patient has kidney disease, we may not even be asking you about the drug. We may be asking you about the patient's ability to excrete the drug. So kidneys are most involved in excretion, and the liver is most involved in metabolization of drugs. Everybody heard that? Metabolism, liver, excretion, elimination. Okay. All right. So this is just going into those same things that we just talked about a little bit more in depth. So absorption, drug particles within the GI tract move into the body fluids. Factors influencing the rate of absorption would be the route and the solubility, which we've already discussed. The first pass effect is when the drug is absorbed by the small intestine. The liver first metabolizes the drug, and the remaining drug is not sufficient to produce therapeutic effects. So there are some drugs that are known to have the first pass effect. And what happens with these drugs because of this phenomenon that occurs in the body, where it bypasses and the liver basically does its thing and metabolizes it real fast and doesn't even give it a chance to work, the patient needs a higher dose for a desired effect. This does not have anything to do with tolerance or anything like that. This is specific to some drugs, and you just need to know the definition of what the first pass effect is. It's when the drug is absorbed immediately by the small intestine and the body cannot really make it available for use. It can't distribute it because it's absorbed and wiped out. So we have to give them a higher dosage. All right, distribution. So let me go back. Okay, so we know absorption. We get absorption. We get that the type of drug, the form of the drug has a lot to do with it. As far as distribution, think back to A&P. What body system do you guys think is most responsible for distributing drugs?
What body system?
Yeah.
The blood?
Yep. You said it, and then somebody typed it in the chat too. Circulatory, yes. So our circulatory system, our lymph and our blood is responsible for the distribution of our medications, okay? So drugs are going to be sent from our gut or from wherever they were absorbed into systemic circulation. And they are going to go to the body tissues and target sites where they are needed. We will talk, if y'all want to just highlight receptors, we will talk about receptors later. You will hear me say receptors repeatedly. When we're in class, I'll have you guys watch a little video about that. But basically, it's kind of like a lock key kind of thing. You have certain things in your body that one thing's going to tell the next thing what to do, tell the next thing what to do. And medications are going to either bind with, interfere with, or expedite those normal receptors, okay? And we'll talk about that later. So our skin, our muscles, and our organs are gonna, they're gonna be a little slower distribution. The heart, liver, and kidneys are gonna be faster distribution, but primarily the circulatory system is how our drug is getting from point A to point B and being distributed to where it needs to go. Okay, metabolism is when the body changes it, like I said, and excretion is when the body gets rid of the drug. Patients with kidney disease require dosage reduction and careful monitoring. And older adults usually fall into this category. All right, everybody still good? All right, the half-life of a drug is the time required for the body to eliminate 50% of the drug from the body. Okay, so drugs with a short half-life are administered frequently. Drugs with a long half-life require less frequent dosing. Does that make sense to y'all? That's why some drugs are given once daily and some drugs are given 3 times a day. Because once 50% of the drug is eliminated from the body, it's not going to be long before we need another dosage of that medication to keep that steady, to keep it steady. So once a day, they have a longer half-life. When you look up drugs in your drug book, it will tell you the half-life of the drug. I will not ask you to calculate half-life, but I will ask you, if a drug has a half-life of, has a half-life of 14 hours, how many times a day would we expect that drug to be given? More than once or less than, would we expect it to be given twice a day or once a day? Yes. Macy's on a roll. We would only give a drug with a half-life of 14 hours once a day, because that means if I took it at 8 a.m., at 8 p.m., half of that drug is still in my system. Over half of that drug is still in my system. So it would not yet be time for another dose. Does everybody understand that? I probably should have given you a more time frame. If I should have said if it has a half-life of 22 hours. Y'all understand that that would only be given once a day, not 2 or 3 times a day. All right. So this is what I was talking about earlier. Patients will often ask you, when will this drug start working? So the onset of action is the time between drug administration, which is when you give them the med, and the beginning of the therapeutic effect. So let's go back to Tylenol. When you take if your temperature is 100 at 8 a.m., you gave your patient Tylenol, and their temp was 101.5. Okay. When 30 minutes later, that temp is 101.1. That medication has reached its onset. It's not fully effective, but it has begun to exhibit a therapeutic effect. Okay. 2 hours later, when that temp is 99.4, it is at its peak. It is absorbed as much as it's gotten rid of, and that is the most it's going to work. Okay. And then the duration of action is the time for a drug to peak concentration is the concentration in the blood. The absorption rate equals the elimination rate. The duration is the time for the drug to produce a therapeutic effect. So like Tylenol can be given every 4 hours. Its duration of action is 4 hours. After 4 hours, that drug is no longer going to give you a therapeutic effect because it's essentially out of your system, unless you have some issues with metabolism or, you know, this other stuff that we talked about. That actual duration of action is only going to be 4 hours. So do y'all think that Tylenol has a short half-life or a long half-life if it's only given every 4 hours?
Short.
Yes. Short half-life. So y'all see where everything's kind of going together? All right. I don't even know what this link from library page is, so just ignore that. All right. So this is how medications work, but I think we're going to skip these slides right now. So hang tight. Let me see. Okay. We are going to, for now, we're going to skip slide. It's going to hurt your brain. What slide are we on? We're going to skip slides 14, 15. Okay. We're going to skip those slides. And we'll talk about them later. They are basically how drugs are going to work. I'm going to post a video and we're going to talk about that our next lecture at the very beginning because I need you to have a really good understanding of it, okay? So if I forget to do that tomorrow, I need somebody to remind me. I made a note, but that doesn't mean anything. Okay, so things that can influence a person's response to a drug. I know y'all already saw my slide, but tell me what are some things that would determine how much of a drug or how well a drug would work on a patient? Be specific.
Like if they had to be like narcotic, something for pain, if they are drugs, it would affect them differently?
Yes, so their lifestyle could very much have a impact on how a patient responds to a drug. So that's a very good one. What else?
When giving a patient like anesthesia, you have to know like their exact weight so you know how much to give them.
Yes, and so Jamaica also said the same thing, BMI.
Yeah.
So a larger person is generally going to need more medication than a smaller person. Now, again, these things are not always, there's gray area, you know, because a larger person with crappy kidneys might not need more of a medication. But in general, your patient's weight is going to have a very big impact on the dosage of medication that they require. So very good job. Yes, ma'am. Gender. Robin said gender. Tell me why, Robin.
Because a woman, I don't know how to say it. Let me say it. Sometimes a woman may need like a, like you know, like a woman may need more of these versus a man may need less of that. I don't know how to say it.
Yeah, so it could go both ways. I was just curious your thought process. So
Does it have to
women,
do with the metabolism between men and women?
yes. So metabolism, and Caitlin just said metabolism. So it has to do with metabolism, and it also has to do with surface area. In general, men are larger than women. So that has a lot to do with it, and their metabolism is different than ours. So yes, gender absolutely has an effect on on how medications are absorbed.
What about age, like children's?
Absolutely. Age is going to be one of the biggest ones that we talk about. Older people, you think they need more medication or less medication?
Probably less. Because
probably less. Yep.
The metabolism again.
Their metabolism slows down. Their kidneys slow down. Everything gets a little sluggish. And more or less of a medication is a very broad term, because old people generally take more medications than do small people. But if they had the same diagnosis, then that would absolutely have to do with it. So age, and then children. Development absolutely has to do with, there's some meds that you just don't give kids who are less than 2, because they are not developed enough to process and metabolize those drugs. So age is absolutely one. I think I covered most of them. What else? Y'all think of anything else? I'm sure we're missing one.
If they have like any underlying diseases that could affect the medications that you put them on.
Perfect. That was the last one. I knew we had missed one. So yes, if your patient, and y'all are going to get sick of me saying it, if your patient has a horrible liver, then they're not going to metabolize medications correctly. If your patient has, okay, let's talk about, y'all know what, we've talked about my skin before, right? So my skin is terrible, right? So whenever the says, oh, put lotion on your skin, when your skin is so incredibly damaged, it can't even absorb that lotion. So you're just putting a layer on top of something that doesn't know what to do with it. So the state of not just their internal health, but their external health. If someone's skin is incredibly thin, they're going to absorb their patch way more quickly than someone who has a whole lot of skin. And then the same goes true for when I did hospice and we would do pain patches. Those pain patches are absorbed into the adipose tissue. So when we would put them on people who had absolutely no fat, there was no absorption taking place. So you can increase those dosages of meds all day long, and if the body can't pull it into itself, then it's useless. So disease, both, well, I guess all disease is internal, but internal as far as organs go, but also your skin is an organ as well. So think about that also. So age, weight, gender, and we've already talked about the route. The route is going to determine the drug response as well, and disease. Very good. Okay, drug reactions. Y'all still okay? Everybody still with me? All right, drug reactions. We are going to have several types of drug reactions. The most common, or I say the most common, the one y'all have heard about the most is allergic drug reactions. We can have patients have drug idiosyncrasy. You will need to know what all of these mean. Drug tolerance, cumulative drug effects, toxic reactions, and pharmacogenetic reactions. So, allergic reactions. y'all have heard of people being allergic to medications, obviously. Y'all are probably allergic to medications. They usually begin after more than one dose of the drug is given. So sometimes people can get penicillin and do fine. And then the next time that they receive penicillin, their body attacks. Their body goes into reaction mode. So just because someone has had a drug previously does not mean they will always be able to have that drug. Allergic reactions can develop at any time in someone's life, okay? Signs and symptoms: itching, skin rashes, hives, wheezing, cyanosis, sudden loss of consciousness, swelling of the eyes, lips, or tongue. So the biggest risk with allergic reaction is anaphylaxis. Okay, anaphylaxis is when your body goes into basically full-blown shutdown mode. Blood pressure drops, your airways close, your angioedema, you have swelling around the mouth, and that your pressure bottoms out and it affects your respiratory system. Okay, so that is the biggest one that we're always going to look for all of the different types of reactions, but allergic reactions are going to be the primary thing that we're looking for. So if a patient is allergic to a drug, what is the very first, okay, so let's just think how I want to ask this question. Okay, your first role in giving medications should be to ask about allergies. It is easier to avoid a problem than it is to fix a problem, right? So you should never, ever, under any circumstances, administer a drug if you don't know what your patient is allergic to. So the first key thing you're going to do is prevent. And then the second thing you're going to do is protect their airway. Make sure that you can protect their airway if there is an anaphylactic reaction that takes place. But you should always, always ask allergies. So I guess I didn't have a question. I just decided to tell you. Okay, so other reactions. A drug idiosyncrasy is an unusual or abnormal reaction, and it's believed to be caused by genetics. So let's say, does anybody know what Benadryl normally does to people as far as a side effect?
Makes them tired.
Makes you
like
sleepy.
drowsy.
Yes. So the normal side effect of Benadryl is drowsiness. Okay. If someone takes Benadryl and they are doing backflips and they have heart palpitations and they're like, whoa, that is an idiosyncratic reaction. Doesn't mean that they're allergic to it. It could still have the effect of the drug, but it has an abnormal response. Like, it's not the typical. So think idiosyncratic is kind of atypical. It's not the expected. All right. We don't talk a lot about pharmacogenetic reactions. They are inherited traits, and they are caused by abnormal metabolism of drugs. And they're specifically patients with G6PD deficiencies. So when the body gets these drugs, it basically goes into, it starts like destroying its own blood cells. These reactions are very uncommon, and generally, people know, like, it's not something. Okay, so this is a question I have for y'all. An allergic reaction can occur at any time throughout life. If a patient has a certain genetic deficiency, they're born with it. So they would have this type of reaction early on, okay? Excuse me. All right, we're going to talk a whole lot about drug tolerance. especially when we get to our chapter about analgesics. Drug tolerance is a decreased response to a drug that requires an increased dosage for the desired effect, specifically narcotics and tranquilizers. So patients who have taken medications their entire life, it doesn't even have to be like they're a drug abuser and then they take pain pills. If all their life, let's say somebody has juvenile arthritis, okay, and their medications are prescription, but they start taking prescription pain relievers at the age of 10. When they're 35, a dosage that would normally help a patient 35 with the same BMI, with the same general appearance and internal and external makeup of that patient who has been taking it for 20 years is going to need a much larger dose of that medicine. That makes sense to everybody, right? Because they're tolerant to that drug. They've built up a tolerance to it, and so their response is not that of their peers. We will talk a lot, if you just want to make a side note, we will talk about the difference between drug tolerance, psychological dependence, and physical dependence. We'll talk about that more later. I'll save that. But those three things are going to go hand in hand. So you need to know what tolerance is now. A cumulative drug effect is when a patient with liver or kidney disease, their body is unable to metabolize and excrete one dose of a drug before the next dose is given. So I used to, one of my first jobs, I worked at the LTAC, and we had a lot of psych patients come in, and they were older, they were geri psych patients, and they would come in and they would need to be medicated with Ativan or whatever, to get them to be safe for themselves, safe for others. And so they would get Ativan and it would work like a charm, and they were still functional and they were fine. And then the next day they would get the same dose of Ativan and they would sleep for 48 hours following that. So that is a cumulative drug effect. That's when their body is unable to fully metabolize and excrete one dose of the drug before the next dose is given, even though the half-life of that drug allowed for it to be given at that time frame. Their body wasn't quite ready for it. Does that make sense to y'all? Ashlyn usually shakes her head, and she didn't shake her head. She's my go-to girl. She's one of the only ones I can see.
I'm still kind of iffy on the pharmacogenetics.
Okay, pharmacogenetics is the one we're going to talk the least about. It's basically an inherited genetic trait. So if a patient says, I have a G6PD deficiency, then we'll know that they can't have certain drugs, and it'll throw up a flag. It is not very common at all. It's not something that it will generally be recognized before they reach us. Like, this is something that's known, long time ago from genetic testing from when they were younger, and their parents had it, and their parents had it, and their parents had it. But if it's not known, it causes hemolysis and all of these things. So if your patient suddenly started having all these crazy bruises, that would still be an assessment finding that you would have to pick up on. But I don't want to say don't worry about it, but that's kind of the least of our worries, because it's not something that we're necessarily going to acknowledge or recognize. I just wanted y'all to know that it's a thing.
Okay, thank you.
You're welcome. And I'll look up the number of people who have it, but it's pretty rare. Y'all get cumulative, though. You get that even though it may be time for the medication, cumulative is going to have a lot to do with your patient's liver and kidney function. They're not through that full pharmacokinetic process before the drug is given again. And then toxicity is when a drug is administered in large doses and the blood concentration level exceeds a therapeutic level. So we do not measure drug concentrations on all drugs. But there are some drugs, so let me reverse. I feel like I'm talking in circles. If a drug is therapeutic, somebody tell me what that means. If I say the drug is therapeutic, tell me what it means.
It has like an effect on the body, like it helps your body?
Yes, it has a positive effect on the body. If a drug is therapeutic, it has a positive effect on the body, or the desired effect on the body, right? Okay, so certain drugs have a number, so like we never draw the blood necessarily for Tylenol to see if it's therapeutic. We just take the recommended dose. There are some drugs that only work if they're between, I'm gonna make it to where y'all can see me, hold on. Okay, so digoxin, y'all have not learned about digoxin yet, but digoxin is a drug that it only truly works well in the body if it's between, I'd be lying if I told you, I think it's 2.5. I don't want to tell you the numbers because I don't remember them, but let's just say it's 2 and 5, just because. So it only works if it's 2 deciliters to 5 deciliters. If it is less than 2 deciliters, it doesn't work at all. And if it's greater than 5 deciliters, then it causes extreme problems in the body. Like it causes tremors and like major adverse effects because it is toxic. Your body then recognizes it as being toxic. So toxicity is not just too much of something, it's too much outside of the range of that therapeutic level to the point that it is harmful. Does that make sense to y'all? Now I need to look up the normal range of digoxin because it's aggravating me. Because I don't want to tell y'all the wrong range because you're going to need to know. Thank you. Who said that? I was way off. 0.8 to 2 is normal. So greater than 2.4 is toxic. You don't need to know that for your test, but that's a pretty narrow therapeutic window, right? So that's what toxicity is. So there are going to be certain drugs that I talk about throughout the course that you are going to need to know levels on. And you're going to need to know, even if you don't know those levels offhand, you need to know this drug has a high risk of toxicity. You know, this is a drug that has a narrow therapeutic range, which means it's either going to work beautifully if it's taken correctly, or it's going to be very harmful to your body or to your patient's body. All right, let me get back to my little reactions page. Thank you for typing that in the chat, Cheyenne. I hate when I have a brain fart like that. I don't like recording myself. I'm trying to get to the right page. All right. So when a drug is, if there is a toxic level of a drug, if it's known, not always, but most of the time, if it's known to be harmful in toxic levels, there has been an attempt to make an antidote, which would be something to cancel that out. But your biggest role in toxicity is knowing ahead of time that they have a low safety margin or a narrow therapeutic index, and to be on the lookout. So we're always monitoring our patients, but if we know something is very toxic to the kidneys, if it's given in too large of dosage, we're really going to even be more honed in on what that patient's urine looks like and, you know, what their output is and all of those things. So just like with asking their allergies to prevent allergic reactions, if we monitor our patient, we monitor those drug levels and we monitor their responses very closely, our patients are going to have a lesser risk for toxicity. Okay, we have drug interactions. So obviously a drug interaction is when one drug interacts or interferes with the action of another drug. So there's several different ways this can happen. And then there are certain drugs that are known to interfere with a lot of things. Like, let's talk about the most common one. Does anybody know what you should, if you're taking an antibiotic, what can it cancel out? Does anybody know?
Birth control.
Yes. Does anybody, well, you don't have to tell me, but usually I have a few people in each class who have birth control or who have antibiotic babies, and their birth control did not work because they were taking an antibiotic. That is a drug-drug interaction, okay? And that is something that, if they're educated appropriately, could potentially be prevented. So there are drug-drug interactions like that. There are drug-drug interactions where, you know, if you give an anticoagulant, which is a blood thinner, with aspirin, you know, you're going to increase that risk of bleeding. So all of these things, excuse me, all of these things are have to be taken into account when administering drugs. So an additive drug interaction is when you give one drug and you give another drug, and the outcome of those two drugs is increased. Okay, so like I said, when you give, if you give heparin and you give it with alcohol, you're increasing the risk of bleeding. Okay, because heparin increases your risk of bleeding and alcohol increases your risk of bleeding, so you have an increased risk of bleeding. A synergistic drug interaction is when you give one drug with another and the sum is greater than the two alone. So it is even, so additive means you're adding to that risk of bleeding. Synergistic means you are really, you're almost multiplying that risk of bleeding. Do you guys understand the difference there? It's like the best way to describe it is the way that I have these math problems here. So additive is 1 + 1 = 2. Synergistic is 1 + 1 = 3. So it's really going to potentiate the effect of that drug. And then antagonistic is when one neutralizes the effect of the other. And an example of that would be the birth control, right? Birth control does not work when you're on antibiotics. And there's many drugs that are like that, that you can't have one thing, you can't take them with one thing, or it's gonna cancel out one of the two drugs. You're gonna notice that grapefruit juice is a common food that's gonna cause an antagonistic effect. What other things are you gonna see? Alcohol sometimes can be, it sometimes causes synergistic, but sometimes it can also cancel out. But knowing what those mean is important. And something I was going to tell you. I don't know. Oh, so back to the grapefruit. So when we're saying drug-drug interactions, you can also, these interactions can also be seen with food. Anything that you're taking in orally. So certain foods can have drug-food interactions, which could cause the same type thing here. And that's what this page is about. Food may impair or enhance a drug's absorption. And then you're going to see a whole lot of, one of the hardest things for me to remember in pharmacology is what drugs should be taken with food, what drugs should be taken without food, what drugs should be taken on an empty stomach, all of that stuff. So those things are important too, because they're going to be a part of your education. So drugs that irritate the stomach, cause nausea, vomiting, epigastric distress, they're often given with meals. And then some drugs require for your belly to be empty in order for them to do their thing, like thyroid medications. And then we're going to learn about all this later. Sometimes there can be a negative effect when you combine certain food and drugs. Like there's certain antibiotics that can't be administered with dairy products, and we'll learn about all those specifics later as well. All right, so what is your job as a nurse? Your job as a nurse is to consult appropriate references in the hospital pharmacist. If there is a question about something, you need to ask. Like if you are just not feeling right about it, if you feel like that dosage is way too high or way too low, or you know that they're not supposed to take it with XYZ, you need to go to your resources. You're never alone in the hospital setting. So you can always reach out to people and make sure, trust your gut, read your drug books, make sure you know why you're giving it, and make sure that you're using the correct references, that you're not just Googling and that you're going to the right places. Observing your patients is key, because that's just your job. Your job is to assess, and if something's going to go wrong, you're going to find it generally during your assessment. You're going to notice that they're more drowsy than they were yesterday. That's an assessment finding, and that might mean that they're having a cumulative drug effect. But if you don't recognize those things and you go ahead and give that next dose of medication, then you're negatively impacting your patient. Recording and reporting, if you make an error, you absolutely have to report it. You can't keep it to yourself. And you have to record that you gave your medications. I have seen a lot of drug errors, especially in paper charting years ago, for nurses who forgot to write down that they gave their meds, and somebody came behind them and gave them again. And the patient didn't say, patients trust you guys. So a lot of times they're not going to say, wait, the other nurse already gave me my meds. When you come in and say, hey, I have your meds, they say, thank you, baby. And they do what you say and they take them, right? So you need to record the things that you do so that you're not the reason that somebody is double dosed. You need to accurately observe and evaluate the circumstances. So you need to take all things into account, not just the drugs they're on, but the foods they're eating, their lifestyle, like we talked about, their age, their skin, all of the above needs to be taken into account, and then using your judgment as well. All right. We're not done yet for the day. I'm sorry. All right, we're going to talk about, before I get off, we're going to go back to how drugs work. I'm going to try to pull up that video for you guys. Would y'all rather me? Let me get out of here. Hold on. Is it hard for y'all to watch a shared video? Would y'all rather me just share it in a link and watch it independently? Is that easier for you guys? I know last semester there was some issues with trying to watch it and the sound and all of that stuff.
Yeah, for me it's easier to watch it individually. I mean, okay. I don't know about anybody else though.
All right. That was kind of the consensus last semester too. But when I do that, I still need y'all to consider it part of your class time, okay? It's not like an extra resource. It's like, you need to watch this video. So we'll do that. I'll let y'all off a little early so that I can post that video. But we need to talk real quick. What questions, this is just kind of an overview. Nothing today was super hard, but it's the foundation, so you really have to understand it. Any questions about anything, any specific examples that you want to ask me about? Everybody feels like it was pretty much general knowledge today. I think nobody feels overwhelmed yet.
So do we have class tomorrow?
Yes.
This class and the other one that we just took, or I'm still really confused on our schedule.
Okay, so the schedule, okay, so this is the only week, because clinicals haven't started yet. You have to ask Miss Adams if you have her class tomorrow. But for me, I'm using these days. So I apologize to the person who sent me, I think it might have been Macy, who sent me an email and asked if we only have class on Monday, Tuesday, and Wednesdays. We do only, but after this week. So y'all will have class tomorrow for me, same time, and you will have class on Friday for me. Same time, but after this week you will not, with the exception of your checkoff in March. You'll have it on Thursday.
Clinicals is going to be on Thursdays and Fridays or Tuesdays and Thursdays?
Clinicals will be on Thursdays and Fridays.
So we don't have class on Tuesdays then, right?
You will. You'll have, so moving forward after this week is over, you'll have Miss Adams' class from 8 to 11 on Monday, Tuesday, Wednesday. And you'll have my class from 12 to 3 on Monday, Tuesday, Wednesday.
Okay, see, that's where I was confused at.
And then you'll have clinicals on Thursdays and Fridays.
And when does clinical start again? Do they know?
I think I don't know. I'd be lying if I told you. I know they're working on it. I think at least, even if it's virtual, you have some sort of clinical next week on Thursday and Friday. It may be virtual, but be prepared for it to start next week.
Miss Trailer.
Yes.
Those clinicals, is that only for students taking med-surg, or is that because I'm only taking pharm this semester? So
yes, there's no clinicals associated with pharm. So if you're only taking pharm, your Monday, Tuesday, Wednesday. Monday, Tuesday, Wednesday from 12 to 3, and that's really it. You don't have any no clinical days.
Thank you.
What other questions? How are y'all feeling? Y'all feel pretty good about the lecture? Everything makes sense? Okay, what chapters are going to be on your first exam? Your first exam will be chapters 1, 2, 3, 4, and 5. And like I said earlier, chapter 3, we will not go into the medical math. We will only go into conversions. So you will need to be able to do the conversions. And what I wanted to say, so everything that, just like it was in foundations, I'm not going to say which of the following is an additive drug reaction. I will say your patient got such and such, and your patient got such and such, and they are now exhibiting such and such. What type of reaction are we, do we think may be taking place? So even if drugs are named, it really won't be the drugs that I'm asking you about. Does that make sense? Because some students get to that first exam, they're like, you told us no drugs. I'm not asking you about the drug. I'm asking you about the patient's response to the drug. So if I say your patient got hydroxychloroquine, you don't know what it is, you don't know anything about it, but I told you that their lips were swelling and their eyelids were puffy, what is wrong with that patient? Somebody tell me.
Allergic
reaction. They're having an allergic reaction. Yes. So I just want to lay that out there. Nobody can attack me because if there's drug names on the first test, okay? So that everything is going to be, not everything, but most things are going to be application. So when you're studying these drugs, what are you going to do for your patient? What are you looking for in your patient? What is the drug being given to your patient for? I need y'all to repeatedly ask those questions to yourself, okay? In regards to drugs working, so I'm fixing to stop talking for like 5 minutes because my throat hurts. Yes, Robin, you can get $1 calculator. And I will post that video, and then we will probably talk about it at the very beginning of class next time, but I need to at least introduce the topic so you know what you're watching, okay? So we'll do that, but I want to make sure that y'all don't have any other questions before I do that. No good? And then what I'm going to want y'all to do is when we get off of this call, because I am like hardcore taking roll this semester. So when you leave, I want you to type your name in the chat bar again so I can make sure you were here the whole time. But we're not leaving yet, so don't do it yet. All right, let me go back to that slide that I wanted to share with y'all. Let's see. I lied, I'm not going to stop talking. I'm just going to finish that way. I'll get coffee when we're done.
Miss Trailer, just because I'm filling out my planner, you said that the first exam is chapters 1 through 5 on February 1st.
Yes. And so what I'm going to do, I'm glad you said that. I am going to post a calendar, and I may have told y'all this already. I'm going to post a calendar that has the whole semester laid out for y'all of when those exams are, what is covered on the exams. But it is tentative because y'all know things change. So if y'all ask, if I don't get through a lecture, and I have to push back a test, then it will change. If I'm done with content 3 days early, then it will have to change, just because I have to kind of go with, you know, with the flow. But I try not to change it. I really do, because I know that y'all plan around those things. So I will post it, but it's another one of those things like, I don't want to hear Ms. Taylor said that, da, 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 da. We can't do all that. Can't do all that. You know, I don't like all that. No whining. All right, y'all can see my PowerPoint, huh?
Yes.
All right. So we've talked about types of drugs. We've talked about the body's response to drugs. We've talked about how different drugs are, you know, some are absorbed fast, some are absorbed slow. But how they actually work in the body, like how does your body know I'm taking, or not necessarily how does it know, but what your body is doing with the drug. So just taking it and having it travel from your stomach to your bloodstream really does nothing, right? Your body has to have some sort of response to that drug. Your body has to know, you know, this is what I'm doing with it. This is how it works. So that's what we're about to talk about now. And students kind of have, either they get this or they don't get it. So I'm going to introduce it, and then I'm going to let you watch that video, which may not be posted immediately because I remember what the link was and now it's not showing that it's available, but it will be posted before tomorrow's lecture, and it's only like 6 minutes. So I'll post that. And when you watch the video, I want you to like take notes and try to be able to explain it yourself. So I know I told some of y'all in foundations, if you can explain something out loud, then you can truly understand it. And if you can't, then you don't really get it. You don't get it enough to really absorb the information. So when I post that video, I want you to really think about how these drugs work. Because if you can understand the concept behind it, then so much more of this is going to make sense. As far as when we start talking about anti-infectives, and I say that it interferes with the cell wall and it interferes with cell wall synthesis. If you can truly understand what that means, then it's going to make sense why some of those medications kill bacteria and some of them just stunt their growth. Like all of those things you're going to be able to rationalize, and they're all going to make sense. So let's talk about this. So drugs can work in several different ways. They can cause physical changes, which would be changes in osmotic pressure, lubrication, absorption. Okay, so something that causes a physical change. So let's say if a patient overdoses, okay, and we give them activated charcoal, okay, when they're overdosing, or, you know, after they've taken all this medication. That activated charcoal causes a physical change to the lining of the stomach so that that medication cannot be absorbed into the stomach. And then eventually the patient's going to vomit, whatever. But that's how it works. Does that make sense, that that's a physical change that occurs? When you apply sunscreen to your body, there's a physical change that takes place on the surface of the skin that does not allow that sun, those UV rays, to be absorbed, okay? That's how that medication works. That's its mechanism of action. You're going to hear me say mechanism of action a lot. So chemical changes, so that's one way that meds can work. They can cause chemical changes, which means they inactivate cellular functions. They alter the chemical components of body fluid, or they change the pH. So the stomach, is it acidic or is it alkalinic?
Acidic.
Yes, the stomach is acidic. So if we are giving an acid, what kind of chemical change are we causing?
I mean, you're getting rid of the acid, so.
So we're making it more alkaline, right?
Yeah.
So if we're making it more alkaline or we're making it more basic, then that chemical change occurred, and that's how that drug works. Okay? So that is its mechanism of action. That's its how, right? Y'all still with me? Okay. And then what we're going to talk about most often is receptor-mediated drug action. And so this occurs when a drug interacts with a receptor in the body and the function of a cell is altered. So a drug molecule joins a reactive site on a cell surface, okay? So it is, if you think about, I'm trying to find a, let me open this and show y'all. And this is basically what the video is going to do, but to just kind of give y'all an understanding. Of course, I can't get it open. Hold on. All right. If this is your receptor of your body, that receptor, can y'all see me or no?
We cannot see you.
You cannot see me. Okay, hang tight. I'm trying to get rid of my thing.
If you pin her task thing, it'll make her picture pop up big.
Can y'all see me now? Okay. So we have receptors in our body. You know, our cells, they communicate with one another. That's how they know to work, right? Whenever those receptors, there's like a million different types of receptors in our body. We'll talk more about that too. But in regards, so if it is a receptor mediated mechanism of action, if it's not working by cellular means like we talked about, and it's not working by chemical means, then it's going directly to those receptors. So you have receptors in your body, right? And stuff only works if it fits in that area, right? If it combines. So like if it's a, I don't know. Okay, let's say a pain receptor. If you have a pain receptor in your body, when it receives that response, you feel pain. If our medications can block that receptor, if they can block it, then that pain can't bind to it. And that's how that medication works, okay? So when we talk about binding, I want y'all to think about a box. I'm going to let y'all watch the video first because it's kind of a lot to absorb with agonist, antagonist. So we're going to talk about all these different things. There's going to be receptor agonist, receptor antagonist, and there's going to be partial agonist and partial antagonist. And what all those words mean is they have to do, if your receptor is a box, it has to do with how that medication binds to that. So sometimes it binds partially and it still lets some of that normal response in, okay? Sometimes it binds fully. Sometimes it has a blocking, like it blocks it and it doesn't really do anything but stop that other response from joining it. So I know that doesn't really make a whole lot of sense, but when you watch the video, it will. And you're going to understand the difference between an agonist, an antagonist, and a partial agonist and a partial antagonist. But all of those terms have to do with how the drug works. They have to do with, and it's the one of three things. Remember, we have the cellular, they can have a cellular response, they can have a chemical response, or they can have a receptor mediated response. All of those things are going to go under receptor mediated. Okay. And that is going to be the same thing as your mechanism of action. That is your how. That is your how your drug works. So that's not usually something that you're explaining to your patient, right? Your patient just wants to know why they're taking it and what it's going to do. What is the expected response? That's what your patient wants to know. But as a nurse, the reason that we have you take A&P and we have you take, med-surg with all the patho is if somebody's giving me something, I want you to understand why this Advair makes me not have asthma. So you might only be verbally telling your patient that Advair is so that you don't get asthma. But we know that it's opening the alveoli and it's da-da-da-da-da because of that receptor-mediated action. So as your career goes on, you're not going to need to remember all that stuff. But for the basics of pharmacology, you really just need to have a general understanding of how these drugs work. Because it will, if you know how they work, you'll know what to look for in your patient. Does that kind of make sense? And you'll know what other drugs interfere with them. Because if it's a chemical drug and it's altering the pH of the stomach, then we're going to know that it probably shouldn't be given with other drugs, right? And so that's how all of that is going to fit in. So I'll post that video for y'all. That's all of chapter 1. Y'all were attentive, the ones of y'all that I could see. So go ahead and sign out, basically. Like, I want you to type your name in the chat. That way I know you were here for my whole lecture. And I think that's it. Y'all have questions? I think we're done if y'all don't have questions. And I will post the calendar that I keep talking about in the important notes section, like in that NTCC section.
Ms. Traylor, can you also send us a picture of those drug handbooks, please?
Yes, I will. That's on my list of things to do. So I will probably post, what I'll do, I'll make a page under week 1 and I'll just put resources. It'll say resources, and throughout the week, I'll just keep adding important information there. So that's where you'll find your video too, okay? And depending on if I find it right away or if I don't, it'll be whether it's up today or tomorrow. But I'll try to get it up for y'all real quick. Okay. Any other questions?
Ms. Traylor, we have lecture tomorrow at the same time?
Yes, tomorrow from 12 to 3.
Okay, want to make sure.
I'm done. I'm just waiting for everybody. Y'all, once you've signed your name in the chat, you can roll out. But I'm not ending the call until everybody has.